Hi. So my name is Marisa Marraccini. I'm an associate professor of school psychology at the University of North Carolina at Chapel Hill. So I study suicide prevention, especially in the context of school settings. And that means that I'm interested in both what we would call upstream suicide prevention programs in schools, where we're thinking about supporting mental health and preventing suicide before any sort of issues even arise, all the way towards more targeted and intensive interventions where we're working with kids who may be struggling with mental health difficulties and also may be struggling with suicidal ideation or have attempted suicide. I'm interested in thinking about other contexts outside of school settings where such children might be receiving treatment or interventions, and bringing the school lens into that work so that we're thinking about how kids can take what they're learning in other settings and bring them into their day-to-day lives, which oftentimes encompasses schools, and also think about how what they're experiencing in schools may impact or influence the type of treatment and interventions that they need outside of schools. So while I was learning to become a school psychologist, I was able to engage in all the things that a school psychologist might do, which in the United States is oftentimes a lot of cognitive assessments, but it's also includes consultation with teachers and other staff around how best to support the social and emotional needs of children, working with kids who were struggling with suicidal thoughts and suicidal behaviors was certainly the most impactful on my work in terms of where I saw needs and where I spent a lot of my emotional energy in being really concerned for the kids that I was working with. And we had a fairly well thought out procedure for considering risk for suicide. I had an interview that I went through and I considered all sorts of things related to risk factors, protective factors that might weigh into my formulation for risk and decision making around who we would need to reach out to. And oftentimes it would mean immediately that we're just trying to pass this child off to someone else who has more expertise, who can support them. So if it's a high schooler who is already engaged in therapy and has had a history of something like this, then we knew that we wanted to reach out to that therapist, assuming we had permission to do so, to consider next steps. However, oftentimes it's not a teen like that. Oftentimes it is a teenager or a high schooler who doesn't have any outside supports. And in that case, typically what we would do is we would refer them to the emergency department. Then when they left, they left. And so that was sort of, it almost felt like that was the end of our role in supporting someone with such high risk for suicide, that we would identify some risk and then we would pass this child off to experts, quote unquote. But what happens really is that the interventions and supports that children receive after they're identified for risk are very imperfect, and they may or may not end up getting the care that they need for various reasons. And even if they do get the care that they need, they generally are coming back into schools. And so what I found is that I didn't have any tools or any training around supporting kids after we identified them for risk and then when they were returning to school. And that was shocking, and I spent a fair amount of time just with one or two students trying to figure out how to help them when they came back. So how did I decide to integrate virtual reality into this work? Because that seems very different from everything I've talked about so far. You know, it was a combination of being at the right place at the right time. I was thinking about the next stage of research and how I can help kids who are coming back to schools after a suicide-related crisis, and happened to be learning about research that involved virtual reality, including exposure therapy or virtual reality exposure therapy. No teen came up to me and said, if there was a virtual reality intervention in the hospital, I think that would be really great. Like, it did not emerge in that way, but it emerged from being exposed to the concept of using VR psychologically and working with teens who are very frustrated with not receiving as much psychological interventions as they wanted, and from spending time with teens who love virtual reality and games and technology, and then just looking kind of at those three areas and bringing it all together, there was just sort of an aha moment, like, wow, wouldn't it be cool if we could let kids practice their return to school in VR while they were still in the hospital? And wouldn't it be better if we could teach them some skills to practice using in school environments and practice that in VR before they come back to school? And perhaps if they can learn some of these skills, practice them in a VR school environment, then perhaps they'll use them when they get to school. Perhaps they'll share them with the adults in their schools to help them reinforce them while they're there. And perhaps they'll just feel a little bit better. And then perhaps that will contribute to suicide prevention for them, because we know that those initial months after a hospitalization are incredibly high risk. And so the more we can provide in that immediate period, the better. And so the way the intervention works is kids learn one of three cognitive behavioral therapy skills, either affect regulation, problem solving, or cognitive restructuring. And then after they learn that skill with the virtual avatar in the headset, in another session, they then go into a school experience. And right now we have 2 school experiences that we've built, with plans to build many more. And we built these experiences so that they would include many of the stressors the teens that we've worked with in this research and in previous research have shared that they might experience when they return to school. So it is not necessarily meant to be a pleasant experience, but it's also not meant to be an incredibly stressful experience. It's meant to match the stress that we think they may face. And because it's not tailored to each individual, it includes an assortment of little stressors that we hope in each scenario there will be at least one that is salient to that specific teen. So for example, there's a setting that occurs in a classroom, and the patient interacts with 2 peers and a teacher. And then there's a setting that occurs in a cafeteria where they have a tray of food and they interact with several peers. And we selected these 2 settings specifically so that we could have one where there's no adult oversight and one where there is. Because some kids are fine with their peers, but very nervous to think about how to make up work and academics and discuss their plan, or being asked about where they've been by teachers. So just to give you a taste of it, in the classroom scenario, we have multiple things happening. So first, there's a book that has potentially content that could be stressful for someone who's recently struggled with suicide. And the idea is that that patient can either practice advocating for themselves to say that this is stressful, I can't read this, to find an appropriate way to do that with the teacher, or they can just read it. So if it's not stressful for them, they move on to the next kind of issue thing. They have peers asking them where they've been. They have a group project where they're a little bit left out potentially, where everyone pairs up and they're the odd person out. And they have a conversation with their teacher. So there's more things that happen than that, but it gives you kind of a sense of how there's a lot of little things built in that some teens may find all of them a little bit stressful. Some teens may find none of them stressful. Some may find 1 or 2. So we built them to try to make it so that anyone could walk into one scenario and it would at least embody something that they might experience and then potentially practice a skill using. Once it sort of builds to the heightened stress level, which we asked teens for feedback around where they thought we should pause, the avatar comes back and reminds them how to use their skill. So in the middle of the scenario, then they practice engaging in cognitive restructuring, and then they go back into the scenario and finish it. There's always a debrief at the end of these sessions between the clinician and the patient, and then at the end of the sessions, the patient and the clinician collaborate on a school-specific safety plan intervention that's built from their real-life experiences and the safety plan that they're probably building anyway in the hospital setting, as well as new information that they might have learned from these VR experiences. So the work really began with focus groups conducted with school and hospital professionals and also teens with lived experience. We had this idea, but we knew that we needed to start from the ground with getting feedback from our community to make sure that we were building the intervention in a way that was meaningful to the folks who would be using it and potentially benefiting from it. So at that time, I felt like, whew, I'm going to continue building this in its skeleton form, in its prototype form, but I better start thinking about ways to expand this because we have all sorts of other ideas for scenarios that we need to build. And I saw that MQ had a call for the MQ Fellowship Award and was very lucky to be forwarded it by multiple colleagues who thought of me when they saw it. And I saw that it required patient and public involvement. And I started reading the call and I thought, gosh, this is such a perfect fit for what these teens are already saying they want for this intervention. And as I started writing the grant application, the ideas sort of all just felt, they all came together. The questions that MQ was asking honestly really informed some of the ideas for the work that we're doing. And we moved with this MQ Fellowship Award away from thinking about how can I just listen to the voices of teens to build the next stage towards why don't I partner with these incredibly brilliant and creative teens to actually make some of these scenarios together. And we're prioritizing co-designing with teens who identify as Black or Brown and or LGBTQ. Really prioritizing these specific populations is in many ways a no-brainer. As a researcher in suicide prevention, but if we look at research at large, we've done a really poor job of prioritizing LGBTQ youth. We've done a really poor job of prioritizing the needs of ethnic and racial minoritized youth. I see so many directions for this work. I would say like a lighter version that children and teens and families could use on their own would be incredibly important because it's one thing to practice this a few times in one setting, but we're really seeing that folks need things at home and in schools. And so the other place that I'd love to see this go is ways that school professionals can touch on these skills and reinforce them in school settings without adding too much to their load, but giving them something very tangible and reachable to be able to support, perhaps in the context of an app. Technology is its own alive, wild creature, and it's ever changing. And so I think that all of these interventions, mine as well as other digital therapeutic interventions, are going to continue to need to be adapted so that they keep pace with what's in vogue with technology and also what's available with technology. And we're gonna need to keep rapidly testing these adaptations on a smaller scale. So I think that this work, I hope, will grow into a place where it can settle into systems, but we can continue to attend to what needs to change and continue to test and refine it so that we don't end up with a VR headset sitting on the shelf of a hospital collecting dust because it no longer loads because it was built 5 years ago. So I think right now it's a wonderful tool, but I want to acknowledge that it may not be in 5 years. And so the goal of this work is to have something that we can keep building on and shifting and changing and moving towards.